from the SELECT monotherapy, these were patients who, it was an unusual patient population. These are patients who were on methotrexate, who had active disease, and in a proportion of these, the patients, their methotrexate was continued and they were given placebo. In the other proportion, patients were treated either with UPA 15 or 30 milligrams once a day with no methotrexate. So it's a monotherapy study, but the patients on methotrexate were on methotrexate. The results were interesting. The ACR20 response rate, there was a 41% response rate with the methotrexate group, which actually seems pretty high. But it may well be that this group was patients who had been on methotrexate, but they were taking it consistently. Now they're in a study, they are taking consistently, so you see a response. In the patients who were switched to UPA, either 15 or 30, they had a statistically significant difference in ACR20, ACR50, ACR70, DOS changes, CDI changes, SDI changes, HAC changes. Both doses were very effective. What was strange in this study, though, was it seemed as though there were numerical differences that were consistent favoring the 30 milligram versus the 15 milligram. And when you looked at safety, there really wasn't a safety difference between 15 and 30 other than more herpes zoster in the 30 milligram group. So if you looked at this study in isolation, then you would assume that the dose that you would want would be 30. Some patients would respond to 15 with no safety signal. But if you take a look at the other UPA studies, such as NEXT, right? Then what you see, you don't see that. What you see is the 15 and the 30 are very equivalent with safety signals that seem to favor the 15. So in NEXT, these are patients who were DMARD, incomplete responders, continued on the DMARD, and then either placebo is added or UPA is added, 15 or 30. And again, that showed that both doses were very, very similar. They're not, actually. There are other studies with UPA that are important. So we've seen top-line results. We haven't seen the publication yet of two very key studies. One is SELECT-COMPARE, which is UPA 15 milligrams plus methotrexate compared to adalimumab plus methotrexate, which is a non-inferiority trial looking for superiority if non-inferiority was met with X-ray. And that is an important trial. The top-line results have been released, and the top-line results at least seem to suggest that UPA 15 plus methotrexate is superior to adalimumab. That's a key study. X-ray also, there was X-ray inhibition with UPA that was very, very similar to adalimumab. And then the other one, which we saw top-line results, was SELECT-EARLY. All right, and SELECT-EARLY is versus methotrexate, which showed that 15 and 30 were superior to methotrexate, which is what we've seen before. So now if you take a look at the whole program, this is a program in which the drug UPA, both 15 and 30, are better than methotrexate, work in conventional synthetic DMARD incomplete responders, TNF failures, and 15 is superior to adalimumab. And when you look at the safety profile would seem to favor the 15. So it seems to me that the dose is 15. And when you look at the side effect profile, the side effect profile is more like tofacitinib than what we've seen in baricitinib in terms of the venous thrombotic episodes, which are still rare, but occur more equally in the UPA program than they did the baricitinib program. So taken together, this drug looks like is going to be a real player. The patients who take the drug. It's all about access, all right? So what I was really saying is if the patient has access to the drug, any patient could have benefit. Are there patients who could have benefit with this drug versus other drugs? I don't know that. I don't know that we know that for any drug. But this drug seems to be effective in a broad spectrum of patients. This is a pretty complete program. They have one other study, which we'll read out in a while, which is also a head-to-head against another biologic, which is ABA. And if that one is also successful, this will be the only drug that's been shown to be at least as effective or more effective than two different biologics. Other than that, the program is really a pretty thorough program. There are always questions that we can ask is if a patient does well and they're on combination, can you stop methotrexate? Or if the patient really does well, can you stop the drug going forward? But those are all questions for the future.